Hello, everyone. We were in Sprint Group 1 looking at innovation in leadership. It was a really lively discussion, really good discussion, and there were two really great examples shared from a couple of ICBs in different regions. They've got very different models for innovation, but there was a common component to the models. One was around having ownership and one person really driving that agenda and bringing others together to then share in that agenda, which they called the Sherpa model, which has been really successful in their particular region. And the other example was where there was, shared ownership, where innovation was baked into the board strategy. So rather than it being a thing over here, that there was nobody particularly responsible for, it was part of business as usual activity, and it was something that got focused day to day, or whenever the board was meeting to look at innovation. We also talked about the fact that innovation, it's not always a big tech improvement or this great big massive program. It can be something really simple, such as a process redesign, looking at operational efficiencies. Doesn't always have to cost money. You don't always have to make those big financial investments to make innovation and change happen. Or it could be care pathway redesign. And then obviously there's all these wonderful innovations and improvements that are out there. Really importantly though, common thing that we discussed at length was about having a really clear definition of priorities and having a really clear understanding of what the objectives are or what the outcomes are you want to achieve before you start the innovation, so you can really illustrate the return on investment and bake that into a roadmap. So Black Country Partnership had got a really good, clear roadmap that had different pillars of innovation that they were focused on, and they were all linked to the Shift Left priorities. And they were measuring those over time, so they made sure that they had that cadence to make sure it would continue to happen, and also have some measures of success defined as well. So not only are they've got it defined, but they also have that continuous monitoring and evaluation of what's happening. Another key challenge, I guess, but also an important thing to take forward is that visibility of innovation. In my world, we go out talking to organisations all the time about their staff survey results, and we always talk about closing that feedback loop. So don't let innovation be something that happens up the top here that's the best kept secret. Innovation, yes, it needs to be owned and it needs to be led, but really it should be part of everybody's priorities, because quite often, especially when you look at co-producing what your priorities are, you need to build that and co-produce that from the bottom up, because often people that are delivering services really do know and understand what the issues are, what the bottlenecks are, what the barriers are, what grinds their gears on a day-to-day basis. So that co-production and making sure that you involve all stakeholders in that process is really critical, not only to embedding it in business as usual, but also to making sure that you get that engagement from the get-go. So it's not just an idea that's thought about at the top and it's cascaded and imposed. It really does help people feel empowered and feel seen and heard. And those measures are in the National Staff Survey across the NHS, where you can see that play out, where people don't feel involved, they don't feel like they've got that autonomy, and they really want that autonomy. So, the other part about visibility as well was not only about closing the feedback loop and making sure that's shared internally, but also looking for mechanisms to do that horizon scanning. And it's the whole adage of you only know what you know and you don't know what you don't know. And if you're not horizon scanning and understanding what industry are doing, then you could be missing really big opportunities to innovate, where you've got a particular problem and you've got all these solutions out there that you're not really sure about. One of the people in our room made a really good point about the fact that a lot of this innovation has already happened, but it's the adoption that's the problem. It's not often the innovation happening, it's the adoption. So one of the things that we talked about is having a really clear pathway for innovation, a really clear process mapped out. So if we've got this innovation, how do we bring it to life? How do we make it happen? How do we get through the IG barriers, the procurement barriers, and all the other governance barriers that can often make innovation stall and sometimes just die on the vine? I've talked about senior accountability and responsibility, building it into the strategy. sorry, it was a long, lively discussion, so I'm just trying to summarise everything we talked about. Closing the feedback loop, I've talked about. I've talked again, but ensuring the objectives and success measures are really clear defined from the outset, because there's this whole ethos around agile methodology and failing fast. But if you don't even know what your success measures are, how do you know if you're failing or if you're succeeding or not? And making sure you've got a really good business case for that innovation. There was a lot of talk in the room about there is no money, but looking at innovation really and looking at the business case and the return on investment, innovation ought to have a case to save money. So you're not having to try and find additional money. If you can prove that you can make the savings and whatever the strategy is to get there, that's the loop, isn't it? You don't need to find this great big pot of money that doesn't exist, because the whole ethos, if it's not saving you money, don't do the innovation. It's probably the wrong thing that you focused on. Okay, and I think the biggest thing was the culture, wasn't it? It's mindset. And being curious and having that growth mindset, try it, improve it, because once you've tried it, you've proved it, it becomes very, very infectious. And often the appetite is very risk averse, and people are scared of changing because sometimes the implications can be really, really big. But if you try a few things that are lower risk, then you get the buy-in and you get the infection, and you can start to see then how it can really accelerate and innovate change and improvement. I think that's about it for me.
Carrie, that's amazing. Thank you so much for summarising all of that as well. Is there anything from session one that anybody wants to cover? Other than that, it's incredibly comprehensive, Carrie, but anything else from anyone in session one they wanted to pick up upon? Great. And Andrew, is there anything else you want to follow up on? Brilliant. Thank you so much. What we're going to do, by the way, I should have said this earlier on, is that all the sort of case studies, all of the notes that have come out of the meeting will be produced into similar reports to the one I mentioned earlier on that we did last year with NHS Northamptonshire. So don't worry if you were trying to scribble down all the notes on that. You will be able to get a copy of that at the end, including further details about some of the case studies that people like Eddie was talking about with Coventry and Warwickshire, but also the Sefner case that Chris and also Ruth, who couldn't dial in because of technology, ironically, will be able to sort of give further information on as well. So thank you. Right, session number 2. Mindy and Fatima, how do you want to present this? Is it both of you guys, or have you got a nominated person?
I'm kind of the nominated person. I'm not sure if should I come up?
Do you want to come up here, or are you okay there?
I'm happy either way.
Yeah.
Can everybody see me? It's on? Okay, great. And this is going to be like, I'm going to jump from place to place. But one of the things that I think we're going to follow on straight from workshop 1 was about that culture piece. And that kind of weaved its way through every single piece that we were looking at. So we were talking about culture being the patient's understanding, the patient's telling us what they want, and us making sure that we respond to that. It's about community, and that's again a cultural thing about making sure that the people who are kind of referring those patients, so what I should say, I didn't actually say what we did we? So we were looking at elderly and UCR care. And we had a really great presentation from Northamptonshire ICB, who told us about what they've been doing. I can't see anybody. I can't see them in the audience, sorry. Oh, there we are. And what really flagged up to us, all of us, are these points I'm going to bring out again, which is all about community was probably one of the biggest points about the fact that they've had kind of feed in from what they call lived expert patients. I've only ever heard it called lived experience, but lived expert sounds so much nicer, and I think kind of elevates them to the level they should be. And it was very much about making sure you pull all the community in to kind of the relatives, everyone in there, to create the kind of equity of access or advocacy, the culture of the staff, and I'm going to keep jumping through it, the data to inform those pieces. So what does the service need to look like, and what there was an example of like how banks can do it so well. Why can't we? It needs to take a really holistic view. And when we come back to that culture, it's also the culture of flagging. So it's making sure that people feel comfortable enough to flag any sort of issues they've got. So it's not that innovations are coming in and saying, this is what we do, and people jump on the bandwagon of it. It's more about us demand signaling to outside, but then we need people within the organizations and the patients, etc., to be saying, I actually need this piece. So it's that flagging up that things are missing. There's also, I said about data, I think data came up probably about 3 or 4 times through this, making sure that data informs whatever we do, so that we're doing this based on the data that this is a needed innovation, or there's a needed gap. Whatever we bring in, it works really well. And then making sure that the outcomes are constantly informed by data. There needs to be procurement. And the procurement needs to be that we are finding the right solutions that will match with other solutions. So it's not just about one innovation that will stand alone, but making sure it's interoperable with everything else. And one of the things that came up was about EMIS, etc., making sure that they're not the ones stopping other innovations coming in, and they're helping solve the problem. Again, staff co-production, which is again all about the culture and making sure that the human factors are kind of brought in as well constantly. The interoperability again, and making sure there's a core set of skills so that the people who are actually working on these areas of need understand what those areas of need are, and then understand if something is brought in, how to actually use the things that are brought in. Let me see what else. Tech. We need to see tech as an enabler, but we first need to listen. Again, another cultural piece is about listening to the patients, listening to what's out there, and it needs to be the right people listening to the right people. So you're hearing from everyone that might have that problem, but then the people also around them, the community. And again, same thing you were talking about. It seems to be we're talking about the same exact problems. And I imagine the next workshop is going to highlight these as well. Yeah.
Perfect. Grand. We're already seeing some consistencies here between the various different sessions, particularly around sharing that knowledge around the uptake of that innovation and across border as well. Very interesting stuff.
Can you ask my workshop to make sure I got everything?
Literally, I was about to ask. Is there anything else anybody wants to cover from workshop number 2? Yes, please.
Mindy did a great job there. Just the funding bit of it around the sustainable funding. So we're kind of very used to kind of non-recurrent buckets of cash landing, quickly use it or lose it. Actually, we need that to resource not just the people, but the tech as well. It just, what's the answer to that? How do you get the sustainable business cases? How do you work towards a really key outcome, and also evaluation of that not being bolted on at the end so that it can continue and avoid the pilotitis Mike was talking about at the beginning of the day.
Brilliant. That's really helpful. Did you guys get into the conversation about ChenMed as well, which I was literally been very excited about since Simon Harlin was briefing me on it as well? Did you get into a conversation about that? Do you want to give like a 30-seconder on what it is? Sorry to put you on the spot, Simon. I'm such a commissioning geek, as people know. It's a very, very interesting model.
So ChenMed's an accountable care organisation for older people in America, and essentially it's about it's identifying the population that you want to have impact for, and then capitating against that, and then the outputs of that are massive improvements in experience, massive improvements in relational elements. So they talk about relational rather than technical, actually, interestingly, but also the value that it adds. So it's delivering at lower cost as well.
Well, thank you.
And what we've done in the Black Country is our Frailty Clinical Network has got a Frailty dashboard, and from that we're able to determine exactly what the cost is and the spend is for people living with frailty in the system. So I think that's a first step to saying, here's your capitated budget, how we're going to do it differently.
So that's a data piece there again that just flows through everything.
Brilliant. Thank you. Sorry to interrupt. Anyone else wanted to bring in on that point? Hopefully helpful. Good. So I'm rattling through this because I'm just conscious of Amanda's time and Paulette's time as well. Session number 3. I know we kind of did a bit of the response back just now, Claire, and Helen's had to dash back to London. But Claire, is there anything else additional you want to sort of feed back on? Do you want to come up? Because, sorry. I know we did sort of halfway house of sort of saying you were presenting at the beginning and then also at the end as well. You might need to just mic yourself up.
Okay. So obviously we were doing Sprint 3, that was looking at innovations in women's health. Lots of synergy with the feedback that's already been shared by the other groups, which is really interesting. We did hear from a really good case study that's occurring in Cheshire and Merseyside ICB, that utilising a women's health app providing support for things like appointments, accessibility with it being published in 75 languages, really tailored to some of the local services and things that are available, increasing uptake in things like cervical screening, and really hearing about some of the impact of the outcomes of that as well. So the fact that the implementation of that app has freed up clinical time, which was one of the key kind of commissioners' challenges in terms of very stretched midwifery services. And I think we heard about a lot of the challenges, around patient engagement. Interestingly, patients engaging with clinicians and clinicians' reactions to women's health problems, I found really fascinating. So there's quite a big education piece there. Access challenges to care, cultural challenges like we've heard about. I think in terms of solutions, there was lots of things that we discussed. I mean, we talked just earlier about how do we get more meaningful engagement between commissioners and innovators and share what's out there. Some stuff about engaging patient voice as well, and really consolidating some of the challenges that the different cultures face in care provision. Lots of stuff about kind of simplifying the pathway, and also, again, I heard in the room about innovators thinking about the whole pathway. Even though your innovation targets a particular area, you really need to think about what impact that's going to have on the rest of the pathway. Resonating messages, really resounding messages, were all about education of clinicians, education of patients, and a lot of work upstream in prevention. Have I captured everything, Luke?
Brilliant. Anything else to add from session 3? No, very, very comprehensive. And the interesting thing from an organiser's point of view, the sort of juxtaposition between elderly and frail, and then also nascent sort of women's health commissioning pathways. I hope once you sort of see the reports that come out of today's sessions that there's a lot to learn from each, because one's at a different stage of the pathway development. I don't know if Amanda's going to, I don't want to put Amanda on the spot in any way, but there's some pretty interesting stuff going on at Nottingham and Nottinghamshire that her colleagues have briefed us about that might be quite useful to sort of feed into that at a later stage. Session number 4, Paul and John, who is presenting from your side? By the way, I'm also loving the fact that this is literally like International Women's Day themed panel as well. This is amazing. I'm so sorry to be on the panel. I'm sorry. All right.
Thank you. I've just got my little notes here as a reminder. We had a huge discussion. So I will do my best, over 2 hours or whatever it felt like. So I will do my best to summarise it, but please chip in, guys. So I think one of the first things that came out was a cultural shift. If we were talking about placemaking and how we can enable this. And what we started to talk about was it's going to be a cultural shift to move care more into the community. And so when people have ED presentations, etc., we want to, instead of admitting them and having them stay for ages, etc., having their medications changed, having their care disrupted, that's not good for the patient, that's not good for community, and then there's this barrier. So what we talked about is how can we move that into the community more, and if we looked, we took some examples from other partners. So if you looked at, for example, police, they've had a big cultural shift about how they can move into the community more, and how they can try and contain and manage all of those issues within community without having to go down that kind of more escalated route. So that was one of the key things that came up. Another one was then the governance, so the enablers, the incentives. We were talking about, I think one of the examples was, if people did want digital options, consultants at the moment aren't incentivised in any sort of way to manage things through email or through digital. So in terms of the way they're paid. So that and things around GP contracts, etc., were another thing that we felt that would actually start to enable that shift into place. A really key one that came up, though, was relationships. So talking about co-locating, especially pre-COVID, talking about that regular kind of linking with partners at a place level and taking time to build those relationships and work on things together. And I think the good examples that we had about the team was how do we enable that, more of that, especially with agile working, etc. But that is still doable. Just how do we enable that? Finding mutual priorities. Now, these were going to be data-led. So obviously the priorities of health are not surprisingly to our partners, the main one. So how can we take local authority priorities, for example, unemployment? How can we take things from the fire service, from police, from education? And how can we use our data and the way we do risk stratification or understand the kind of the groups that we want to support and target and find that overlap so that we can come together as the sum of our parts? I think the discussion very much focused on we're all going to have, maybe not quite in the same way that we otherwise would have, and we're all going to have our regulatory responsibilities and requirements that we're going to have to deliver. So how can we find a way as working as individual organisations to deliver but also come together as partners was a key one. Data sharing and IG came up quite a bit. If there's one thing I would like to push, that would be it. So if we want to solve something nationally, I think how we enable that so that we can share insights across partners and across health services is an absolute key enabler of all of this. And I think, having that insight, having that informed decision making, having that insight to work on as partners is really key. And that's been shown time and again through the conversation. So that was an absolute key. And then finally, commitment to the long term. All of our measures are very short term. All of our measures from the group felt very short term, or the funding felt very short term or uncertain. So I think, again, a key thing there that came out of the group discussion to manage and support places is how can we give that commitment to prevention to that long term while also managing, obviously, the short term performance. And we understand that there's got to be that return on investment, and how do we measure and demonstrate it? But more importantly, how do we balance the two? I think that's a fair summary. Is that okay? Good. There's a lot more post-its than that, but I felt everyone was getting tired, so thank you.
It's because the award to pay. Would you like to come up and take a seat? But you can come and grab a seat. Come on, grab a seat. Good. People are going to ask some questions to people. So sorry. See, this is the bit I didn't put on the briefing for obvious reasons. Sorry. Any other thoughts for session 4 that might have been missed, or anyone else from session 4 that wants to just contribute to feedback? Yes.
You summarised it beautifully, you really did. But I'm aware we've got some political stakeholders here, and you would have to be either insane or fantastically courageous to tackle two of the really crunchy ones, which was national IT solutions that really do work and deliver into the healthcare space and deliver for patients, and the GP contract. You'd have to be either insane or incredibly brave. But I think they're two key enablers, actually.
Perfect. I might not exactly phrase that when I introduce Paulette in a minute, but yes, you've got a good point. Sorry, and Paul, yes. Do you want to come up?
Yeah. Just want to say a quick thing about the money. So, if you're going to try and scale innovation and build strength in neighbourhoods, then you need to not only have a shared agenda, as Marion was saying, but you need to incentivise it. So that might mean new tariffs for primary care, for doing things that they don't currently do. It might mean new primary care contracts. It might mean role redesign. It might mean shifting of budgets from one place to another. And so a lot of what we talked about was cultural stuff, cultural alignment, getting shared visions and fixing some of the basic things. But actually there's an elephant in the room here, which is money. And we've got to make sure that the money flows in the right place and incentivizes the right thing. So when we were thinking about being insight-led in the design of services, we had quite a good discussion about if we were like marketeers, how would we understand, where the value is in the population, and how do we incentivize against that value, didn't we? Which is kind of the point that gentleman in the back was making about accountable care in the States. So that's what I would say.